how do you treat the symptoms of atrial fibrillation? Well, remember, the symptoms of atrial fibrillation are primarily caused by the rapid speeds that the atrial fibrillation tells your heart to race at. And the faster it makes your heart go, the more symptoms you're going to have. The less fast it makes your heart go, the more you may have episodes that you don't even feel. So you can't always feel when you're in atrial fibrillation. You just feel how fast your heart is going. And if you're just a little bit faster than your normal rhythm speed, you may not even know. The EKG will always tell us whether you're in atrial fibrillation or not, but you yourself can't always tell. Now, when your heart rate goes fast in atrial fibrillation, it definitely causes symptoms. The faster it makes your heart go, the more symptoms you're going to have. It's like you running fast on a treadmill, or when you were a teenager running a mile in PE class and you're feeling severe palpitations, chest discomfort, chest tightness, shortness of breath, fatigue. These are all symptoms of a rapid heart rate, and atrial fibrillation can cause that. So how do we treat those symptoms? Well, remember, we said we're treating atrial fibrillation symptoms just for symptoms, not because the AFib is directly dangerous or life-threatening when it speeds your heart rate up. True, atrial fibrillation can lead to a small clot in your heart that might break loose, go to your brain and cause a stroke. But if you're on treatments for that, and you're not felt to be at significant risk for clots and strokes, then everything else we do is just for symptoms. And how do we treat the symptoms? We have various ways of treating the symptoms, but it's important to understand that we are just treating symptoms. AFib is not one of the directly dangerous, life-threatening heart rhythms that can make your heart go at 300-400 beats per minute, make you pass out and die. AFib makes your heart go at exercise kinds of speeds. And so the treatments for atrial fibrillation are based on the pros and cons of the treatment and how symptomatic the patient is and their age, risks, and risk tolerance. So all of those things combine for us to help decide with you as the patient what's the optimal treatment for your specific situation. It should not be a cookie cutter approach where somebody comes in, spends 5 minutes and just says, oh, well, you just need a procedure or you just need this particular medicine. No, it should be, what are your symptoms? How much symptoms are you having? How much AFib are you going in and out of? What stage of AFib are you in? How old are you? Are you somebody who's older, who wants to do less risky things versus more risky treatments? Are you somebody younger who's willing to do more aggressive treatments and get a better, longer lasting result? And what's your risk tolerance or your philosophy? Are you somebody who wants to fix the problem and you're willing to take some risks to do that? Or you're somebody who wants to do the most conservative, least risky thing possible? See, there's two kinds of problems in medicine, at least in my view. There's two kinds of problems in medicines. There's dangerous, life-threatening problems, and there's problems that are just treated for symptoms, but they won't directly kill you. Now, if you have a heart rhythm problem that I believe is directly dangerous and life-threatening, and you could die from it, then I'm going to tell you that. I'm ethically obligated to let you know that, hey, this problem can kill you, and out of the 5 different ways I have of treating it, I'm going to choose the way that I think has the greatest chance of you not dying, and I'm going to tell you, I think this is the best treatment option, in my opinion, to save your life. But if you're dealing with a problem that's not directly life-threatening, but that we're just treating for symptoms, there might be multiple ways I have of treating it. And they're not necessarily right or wrong. They're pros and cons, risk and benefits. So for example, in atrial fibrillation, we have 3 major categories of treatment that go from less risky to more risky. The less risky treatment options have a shorter term effect, but they involve medicines that have less risk, less side effects. Or you could do a procedure like an ablation procedure that has more risk up front, the most risk up front compared with a medication, but might get you a longer lasting result. So for example, the first group of treatment would be rate controlling medications. These are simple medications that really have no dangerous long-term side effects. Many of them are used to lower blood pressure. And all they do is slow your heart rate down. So you're still going in and out of AFib as much as your stage predicts what stage of AFib you're in. But what we're trying to do is we're just trying to slow it down enough where you don't feel it as much. And sometimes this works, especially in the early stages when you're not in AFib very much and you just want it slowed down enough so that when you have an episode, you just don't feel it as much until the episode is over. or in the latest stage, the permanent stage where you're 100% in AFib, and this is all we can do is just slow it down to a level where you can tolerate. These are the two stages where usually this has the most effect. But think about it. When you have a medicine to just slow it down, you're not actually getting the person out of atrial fibrillation. You're just slowing it down enough for them to tolerate it, the episode until it's over. So you're not really doing that much, but it's not a very dangerous medicine with any kind of long-term side effects. And even non-cardiologists can prescribe these, and there's no problems with that. But then if you say, hey, that's not good enough, I'm still feeling my AFib even though it's slowed down, but I'm still feeling palpitations. I want to have a better result. I want to not be in AFib. Can you make me not go into atrial fibrillation? Well, then you have another set of drugs called antiarrhythmic medications, and these drugs are stronger. They actually try to keep the AFib cells asleep so that you don't go into AFib as much. It alters the properties of your electrical cells to make certain kinds of cells, like AFib cells, less likely to wake up. So you actually have less episodes of AFib. And sometimes the medicine works well. You may have virtually no episodes of AFib, and it almost feels like you're cured of the AFib. Now, you're not really cured of the AFib. The medicine is keeping the AFib cells asleep, but they are still there, and they can still wake up just as much as before if you stop taking the medicine. But this is doing more and getting you a better, longer-term result. But the flip side is these medicines have stronger potential side effects than the medicines that just slow things down. And then you have the ablation procedure. This is a procedure where we can map these AFib cells inside your heart, find out which walls they're on, and then try to destroy them from the inside with an energy source, whether you're talking about cauterizing it or freezing it or denaturing the cells, which is a newer modality that kills the cells without actually burning or freezing. Different ways, but if you can get rid of the cells from the inside, while that's never a permanent cure, it could be a long, long time, sometimes years before the AFib grows back and starts to wake up again. So you could get the longest term results from an ablation, but all ablation, it's a procedure. It may not be open heart surgery, but it is a procedure, and all procedures have risk of complications. So you take the most risk up front to try to get the longest lasting result. But you see, none of these treatment options is neither right nor wrong. It depends on your specific situation. I have people, who are older in their 70s and 80s who say, look, at my age, I don't want to do anything super risky. Do the least risky thing possible. I don't need the perfect result. Let me go in and out of AFib. Just slow it down so that I don't really feel it or barely feel it. I can tolerate it, and that's good enough. Because, I'm in my 80s and, I just want the least risky thing possible. I just want to feel good. And you just told me this is not directly life-threatening. On the other hand, I've had people in their late 70s or early 80s say, look, I understand the risk of a procedure is more risky and I'm taking more risk up front, but that's my philosophy. I'm willing to take extra risk. I'm willing to take that extra up front to try to get a better, longer lasting result, because my philosophy is fix it and only use whatever medicines if you can't fix it. And that's their philosophy, and that's how they feel, and that's maybe the right decision for them. On the other hand, if you were in your 50s, 60s, early 70s, and otherwise healthy, you might go, look, why would I just want to slow this down and tolerate it? Maybe I do want a stronger drug to keep it suppressed or asleep, or maybe I want to consider an ablation procedure and try to get rid of this long term for many years. I'm willing to accept a small 1% risk of a complication. On the other hand, I've had 50-year-olds tell me 1% risk is too high of a risk. It scares them, and they would never do that under any circumstances unless they failed all drugs, and even then they'd have to think about it. So I'm not here to tell you what your risk tolerance is. I'm not here to tell you what your philosophy is. Well, what we're here to do is we're here to try to give you the proper information, the pros and cons of the treatment options, and make you realize that symptom-wise, the symptoms of rapid heart rates and AFib, we are just treating for symptoms, not because that's going to directly kill you, as long as you don't have a clot and a stroke, which is a separate form of treatment. And that whether you choose to just slow it down and tolerate it, or you choose to do an ablation to try to get a longer lasting result, this is based on your own personal preferences, how much symptoms you're having, because obviously the more symptoms you have, the more aggressive you're going to want us to treat it because you're feeling miserable. And then also your age, circumstances, and your philosophy of life and your risk tolerance. So all of these factors weigh in to make sure we help you come up with the right answer for your specific situation at your specific current stage of atrial fibrillation.